So does breathing and medicine meet? Well, in some instances it does. And Dr. Louise Oliver is going to tell me absolutely that's the case. Dr. Oliver is a GP and she's based between Leeds and Manchester. And this conversation is all going to be around the whole application of breathing for females. And of course, I'm sure it's going to go in different directions. So I'm going to pass it over to you. Louise, it's a pleasure. I know we've had you on before. I know that you can really give valued contributions based on your experience and also the application and your knowledge of breathing in that space. So I'm going to ask you first, how did you start or what got you into breathing? Because there's not so many GPs with an awareness of breathing. I think it's great, but how did you start?
So partly I became quite disillusioned with medicine probably about 8-9 years ago. I didn't feel I was helping patients as I wanted to. I just became a doctor because I wanted to help people, and people are complex, and a lot of complex problems, traditional medicine can run out of options. And then along that way, I went down a really unstructured journey, learning about mindfulness and neuroscience and mind-body breath connection. But then I started snoring. So in my perimenopause, I started snoring, and I really didn't think there was any problem with my breathing at all. I was running 3 times a week. But in retrospect, I know now that when I was about 10, another pupil in the playground told me to suck my stomach in so it wouldn't look as big. And I think I probably stopped using my diaphragm at that point. And I think women don't realise that if they're holding their stomach in, it affects their breathing. And your diaphragm, that main breathing muscle under your ribs, it's a muscle, and if you don't use it, it gets weaker. And then you start to breathe more upper chest. And then as you go through medical school, you get a bit stressed. So I probably started breathing more upper chest, mouth, fast. And then I talk a lot for my living, which is not necessarily very good for breathing. And then the tipping point for me was the changes around the perimenopause. And I'm really lucky that obviously I came across your work, and I essentially, with your help, retaught myself to breathe as nature intended. My snoring stopped, and like my functioning so much better. You know, I feel calmer, I can exercise with greater ease, and my sleep is just the best it's ever been. And obviously I want other people to know about that. It's a piece in a jigsaw of health and well-being. I'm not saying it's relevant to everybody, but if you don't know about it, you can't assess whether it's relevant to you.
And I suppose the other thing is as well that often comes into my mind is that people have different perceptions of breathing and that not all breathing is the same. Because sometimes I know if I had a conversation with somebody and if they don't know about breathing, it's almost that their eyes glaze over and they automatically accept that they know all about breathing. And it may be hyperventilation techniques or something else, but not all breathing exercises are the same. And can you kind of just tease that out, like in terms of in your world, the perception of breathing is probably very woo-woo and left of field. And I can understand that because very often that's the way it was taught. But that shouldn't be the case. We're just talking about normal physiology here and processes. And even that paper we looked at a moment ago on Alzheimer's, and it said that the brain consumes 20% of our oxygen. And most people don't realize that we can actually influence blood flow and oxygen delivery to the brain. So I'll pass that over to you.
And it is, you know, I mean, I've been a doctor, I've been a GP over 20 years, and, you know, I was taught this stuff at medical school, but I wasn't taught the practical application of applying it to patients. And I think, you know, we just think we're either breathing or we're not breathing, or maybe we're in like casualty and we're having sort of acute respiratory distress. But actually, it's way more complicated than that. We can breathe efficiently as nature intended, or we can breathe inefficiently or anywhere in between. And I clearly started to not breathe efficiently, probably around 10, and it just slowly deteriorated. And then when it hit the tipping point, that's when I noticed. And I think in medicine, we separate things. So we separate things into how, you know, one aspect of respiratory medicine is how we breathe when we're awake. And one aspect of sleep medicine is how we breathe when we're asleep. But we're not an awake and an asleep person. We are a whole person. You know, if I'm not breathing efficiently, you know, because I've got breathing pattern disorder when I'm awake, it's highly unlikely I'm suddenly going to start breathing efficiently when I'm asleep. So to separate the two just doesn't make sense. And obviously as a GP, because I have to have that holistic view, it probably is a bit easier for me. And obviously, you know, I've been on the receiving end of it as well. And I've noticed, you know, when I changed how I breathed when I was awake, it really helped my breathing when I was asleep. And I'm not saying, you know, you're going to cure all obstructive sleep apnea by changing breathing patterns, but it's just the basic natural foundation to make sure that someone's breathing efficiently. And I think, you know, the more chronic disease that people get, in the 3 hormonal transitions of life, women's breathing changes, and people don't know this. You know, I didn't know this as a doctor. So at puberty, pregnancy, and menopause, we're more likely to get a blocked nose. So puberty rhinitis, pregnancy rhinitis, and menopausal rhinitis. And if people don't know the importance of breathing as nature intended using the nose, then they'll start to mouth breathe. And the more you use your mouth to breathe, the more your nose gets blocked. And then it's just a vicious cycle. At puberty, before puberty, we've got more boys than girls have asthma. After puberty, we've got more girls than boys. You know, we need research on that. You know, what do we do to girls when they go through puberty? We put a bra around them. We're actually restricting their breathing. You know, do we need to rethink that? Do we also need to think about girls that, you know, if they're getting embarrassed about breast development and they're starting to sort of hide themselves, actually that's going to restrict their breathing. You know, we need to talk about that. Perhaps that should be discussed in schools when they're having their, you know, education around periods, etc. When women go through pregnancy, there is a steep rise in sleep disorder breathing. And I think, you know, if anyone's been pregnant and carried a baby till around term, you know, I don't think any of us would say that breathing is like as good as it was when we started it, you know, when we were just before we were pregnant. We know how difficult it is to breathe when you've got a baby inside of you, for various physiological reasons. But again, you know, if you start that pregnancy and you're breathing this fast at rest, you're going to hit that tipping point sooner than if you'd like, oh, shall I improve my breathing? And I'm here, and oh yeah, my breathing will deteriorate, but it won't get to the point that I'm snoring and got obstructive sleep apnea. And I can delve further into, there's a little bit of work on that if you want to go into it. But and then obviously with menopause, for different reasons, there's a steep rise in sleep disorder breathing again. And so all these hormonal changes are affecting our breathing. And I would love women to know, you know, at these hormonal changes, my breathing might become more inefficient. Can I assess my breathing before and work on it if it's not as efficient as I thought it was? And that might actually help those transitions. But obviously that information isn't out there yet. So.
And even in, say, for example, the different phases of the monthly cycle. So when you're talking about women then becoming more aware of their breathing, what do you think they should be looking out for?
Well, I think first of all, just they have to be aware that breathing isn't necessarily automatically efficient. So just bring your attention to it. The simplest way is obviously whether you're using your nose to breathe, and obviously that's breathing in and out. So that's a really simple way. You know, when you're at rest, can you hear yourself breathing? Because really at rest, we shouldn't really be hearing ourselves. We don't need to breathe that heavily. You know, are we sighing and yawning a lot? You know, I have some clients who are definitely nasal breathing in the day, but they sigh and yawn incredible amount, so they're over breathing. If we talk a lot, you know, I'm over breathing now. I know I will be, because I'm concentrating on the conversation. But if you talk a lot, again, you can over breathe. So it's just, and if you've got a blocked nose, you're more likely to use your mouth to breathe. How do you breathe when you're asleep? Is your mouth open? Are you noisy with your breathing? Do you stop breathing when asleep? Are you excessively breathless for the level of activity? So it's those sort of questions that we, you know, just get curious, just observe what happens to your breathing. And I think another one is, and we've discussed this, is people holding their breath on the inhale when they're on electronic devices or in a situation that drives a fight-flight response. So a sort of like, you sort of hold your breath on the inhale, and it's the body's response to a perceived threat. And obviously, you know, phones and computers are not natural to this world. And then the body almost is surprised by the buildup of waste product because we've held our breath, and then the person will probably overbreathe afterwards, but it can actually over time make the breathing quite unstable, and actually probably fuel anxiety. And I think that happens a lot. So and it goes unnoticed.
Some of our listeners will be familiar with overbreathing, but some may not. And the concept of overbreathing, you know, because we think oxygen is good and get rid of the toxic carbon dioxide. Can you just explain a little bit about the physiology that breathing is not necessarily what people may at first glance think it is? So where is the balance there?
So generally, we only need about 6 litres of air per minute. And actually, some people with asthma who are poorly controlled can breathe 14 litres of air per minute. I mean, you know, I actually measured that out for a social media post. It took me ages to fill up 14 litres, and 6 litres was really easy. And to me, I thought, oh my goodness, how difficult is it for someone to breathe that volume per minute? I mean, that's crazy. But essentially, we don't need a lot of air. And if people just think of this concept that when at sea level we breathe in and 21% is oxygen, but we breathe out and 16% is still oxygen. So we haven't used up all the oxygen, even even when we're exercising, it's not zero on the exhale. So if anybody hears the phrase take a big breath to get more oxygen, it doesn't make physiological sense because we're throwing out oxygen we're not using. The issue is getting the oxygen from the blood or on the blood cells into the tissues. And actually that involves different things. It can involve heat, carbon dioxide, and something that we make with regard to altitude training. So, but I think the big thing is, you know, our waste product carbon dioxide actually helps release oxygen to the tissues. So actually, the more tolerant we are to our waste product, the more our body will release oxygen to our tissues. And I think we've lost that. Well, I knew this. I was taught this at medical school in my first year. And when I did my breathing practitioner training with you, I actually went back to my 30-year-old year textbook. I was taught this. Why wasn't I taught the practical applications of it? So air hunger, that feeling of suffocation when we hit that carbon dioxide tolerance, it's not necessarily a bad thing, and we can train that to be better. And I think it's profound. It really makes a difference to people.
And I think it ties in as well with the conversation that you had. So say, for example, hormonal changes, and especially the likes of progesterone, that it stimulates respiration. And the female then is breathing faster and harder and putting her into overbreathing. But you said if her everyday breathing is pretty okay,
Yeah.
and then when there is an increase in progesterone, yes, her breathing will increase, but she'll still be doing pretty okay.
Yeah.
It's when a female doesn't have good breathing. And the next thing is there's an increase in progesterone.
Yeah.
So there's poorer breathing on top of already poor breathing, and that's going to put her into symptoms. What symptoms could be caused for females, or what might they experience if they have times of overbreathing?
So I think this is really, really interesting. And certainly, if we've got listeners that have premenstrual tension, they're really struggling with the perimenopause or progesterone intolerance, just consider, could it be related to how I breathe? I'm not saying it is, those are complicated areas, but exactly what you say, it's completely under-recognised that progesterone is going to make you breathe faster, and does that tip you into symptoms of hyperventilation? And when you look at the symptoms of hyperventilation, they're very similar to symptoms of the perimenopause and premenstrual tension. So, you know, things like brain fog, pins and needles, an inability to feel like you can get air in, fatigue, poor sleep. Gosh, I'm struggling.
Yeah, increased pain,
Or increased
headaches,
pain. Yeah, yeah,
yeah,
complete.
anxiety, panic disorder.
Absolutely. So all those things, is it related to the hormonal changes, or has it just tipped you into
Mm.
breathing so much that it's tipped you into those symptoms? It's just a question, and for people to think about, but I think really important.
It kind of brings to mind, there was a study that was published back in 2006, and I'm going to try and pull it up here. And it was looking at the link of between hyperventilation and premenstrual syndrome. And the researchers asked a question, could the symptoms of PMS be caused by hyperventilation? Now, the researchers also spoke about, now it's only n equals three individuals that they're looking at. Unfortunately, it's a very small study, but I'm just going to put it out there because the one thing about breathing is that there's no side effects if you're doing everything nice and gentle and the stuff that we're talking about in and out through the nose, etc. So they had 3 women with severe symptoms of PMS, and they noticed that during the luteal phase of the cycle, there was a dramatic decline in end-tidal CO2. So Louise talked about carbon dioxide. It's not just a waste gas. It is the primary driver to breathe. And it's carbon dioxide that actually facilitates the release of oxygen from the red blood cells to the tissues and organs. The conclusion was that the symptoms of PMS observed in our patients were associated with a pronounced decline of end-tidal CO2 that occurred during the luteal phase of the cycle. But the symptoms were similar to the symptoms observed in chronic hyperventilation syndrome. So it is suggested that some of these symptoms may be caused by chronic hyperventilation syndrome. Quite a few women suffer from severe symptoms of PMS, and yet the link between their breathing and their symptoms is overlooked. But I suppose that's perimenopause as well.
Yeah, I think it's obviously these are complex areas, and you know, I think they're a jigsaw puzzle to try and and each person's different, obviously, so different aspects will be relevant to different people, but it's just, if people aren't even aware it's a possibility, then they're just being robbed of the chance of considering how they're breathing and whether improving it could help. And as you say, really, it's not, as long as you do it gently and you don't give yourself too much sort of air hunger and that feeling of suffocation, it really, you know, it's actually can feel quite nice, you know. It's you know, there's nothing really to be lost by it, and all we're trying to promote is just to return back to how we've been biologically programmed to breathe. So it's not weird. We've just forgotten how we've been designed, you know. We just think how a baby's been born in this world to breathe, and it's in and out of the nose, and it's gentle, and it's using, you know, it's using the diaphragm. So
another aspect in female health is the whole aspect of postmenopause and the symptoms and sleep disorders. Can you talk a little bit about that? Sleep apnea, upper airway resistance syndrome, and I suppose things that females, if they're going through that period of time, what should they be looking out for?
So obviously our bodies completely change as we go through perimenopause to postmenopause. You know, we're losing a hormone that essentially is an anti-inflammatory hormone. So if people don't know about inflammation is a good thing. When we've got a virus or we sprain an ankle, you want inflammation to heal or to get rid of something, a foreign body in our body. But when we've got excess chronic inflammation, it fuels all the chronic diseases. So it fuels depression, hypertension, you know, high blood pressure, heart attack, stroke, diabetes, all the chronic diseases generally are fueled by excess chronic inflammation. So obviously we've got to think we are going to have more inflammation, and that means what can we do to offset that? Well, we want our breathing pattern to, if we can, lower that inflammation. And if we breathe slow, gentle, using the nose, using the diaphragm, it strengthens the vagus nerve, and the vagus nerve actually helps get inflammation down. So I think that's a real key that women need to know, that, oh, I can offset the extra inflammation that I might have in my body by strengthening my vagus nerve, making sure I'm breathing as nature intended. And I think the real important part is how we breathe when we're asleep, because as women go through perimenopause to postmenopause, we've got this steep rise of sleep disordered breathing. So, you know, we're more likely to sleep with our mouth open, we're more likely to snore, we might stop breathing during sleep, so that's obstructive sleep apnea. And there's another condition which you've mentioned, upper airways resistance syndrome, and that's more when the airway, the tube that we're breathing through, the airway becomes narrowed enough that the body feels a threat to life. It might not necessarily close completely or drop your oxygen too much, but it's narrowed enough, the body feels threatened, and it has to generate a fight-flight response to open it. And when we generate a fight-flight response, we're going to create more inflammation, more cortisol, and also the most likely part of the sleep that's going to happen is in our deep stages of sleep, because all the airway gets floppy. And that's the stage when we do all our repair and recovery. And I think, I think we really need to think that when people are asleep, their fight-flight response should be turned down, and their relaxation parasympathetic response should be turned up, and then the body can do all those wonderful repair processes that it needs to do. But if we're breathing in a way when we're asleep that's driving that fight-flight response, that person they're going to have more inflammation, they've got more risk of chronic disease, and it's not always that obvious. It's so easy to miss. And it's much easier to correct the earlier you notice it, rather than obviously wait until someone's got severe obstructive sleep apnea to treat it. And I think particularly, we have to really think when we're asleep, we consolidate our memories, our learning, our processing our emotions, we repair and recover our ligaments and muscles, etc. We get rid of our waste products from our brain, and if we're not breathing well, it interferes with that. And there's been a recent paper that describes the musculoskeletal syndrome of the menopause, and for me, I completely agree with everything in the paper, but there's one missing bit that they're not considering. Could the way the woman is breathing while they're asleep be impacting that musculoskeletal syndrome of the menopause? So increased inflammation, more joint pain, muscle pain, and more bone loss and more muscle loss. And I think that's really important, and we've got to create more awareness about that.
And I think it really does. Like, it's been said that the whole sleep industry evolved around men. Sleep apnea is very much traditionally regarded as a male disease. And if a female's AHI, in other words, if she has between 2 and 5 events per hour, that's equivalent to a man having between 10 and 15 events per hour. And that doesn't be taken into consideration, because a female may do a sleep study and the sleep doctor might say, well, your sleep apnea is less than 5 events per hour, so technically you don't have a sleep problem. But she does. Do you notice in terms of your own patients the symptoms that they may have? Because people might think, well, if I have poor sleep, surely I would be waking up feeling exhausted. But females can experience symptoms a little bit differently to men as well.
Completely. Women are completely different from a sleep disorder breathing point of view. I mean, it is described in the research, they're more likely. They don't come in. I've not, perhaps now, because I'm more on social media, somebody might come in and tell me about their snoring, but certainly generally people don't come in. They come in saying they're exhausted, they're waking up with morning headaches, they're having nightmares, they're feeling anxious, they're waking up with palpitations. There's all sorts of things that they can present with. And it's a consequence of how they've been breathing when asleep, but they're not making that link. And when I ask, what's been really interesting is when I just ask this question: do you sleep with your mouth open? Do you have noisy breathing when you're asleep? Do you stop breathing during sleep? And so many people know how they breathe when they're asleep, and they'll just tell me. There's a small proportion that don't, and then they have to sort of go away and think about how they're breathing, maybe using an app to record it or something. But people laugh about rattling walls. You're on a 3-story house and they can hear, they're in the top story and the person downstairs can hear them. People won't go on holiday with them. Their sleeping partner's literally getting them, nudging them to make them breathe. And they laugh, and I know physiologically what happens to a human body when you breathe like that when you're asleep, and it is not a laughing matter. It really is very serious. So to me, it's not that people don't know how they breathe, or I'd probably say like 70% do know of my patients, but it's like this complete disconnect that actually impacts sleep. And And then, you know, I used to always think if someone was tired and I've done a blood test and it doesn't show any reason for tiredness, that's okay. That's everything that I've checked. But actually, you know, should that person actually have a sleep study? Because you've not excluded that they've got undiagnosed sleep disordered breathing. And I am sending patients now for sleep studies, even if they're telling me they've got normal breathing when they're asleep, if they've got lots of risk factors for it, I am sending them and insisting that they go. And I've had positive sleep studies come back. So I think the whole upper airways resistance syndrome part of it, we can easily miss that on a sleep study. And actually that can impact daytime functioning worse than some of the mild obstructive sleep apneas. And I think we need to recognise that, and we need to have more discussions, more research about it, because I think we're missing that in women, and particularly in complex medical problems, I think.
Yeah, upper airway resistance syndrome. It was first coined by Dr. Christian Guilleminault in 1993. And the debate in sleep medicine, is it part of the continuum from snoring? Does it lie somewhere between snoring and obstructive sleep apnea? And Dr. Christian Guilleminault's belief is that it lies in a completely separate spectrum. The thing about upper airway resistance syndrome is exactly, you explained it really nicely. So the airway is narrowing. So this would be the throat or the air pipe, for example, to make it easy. The airway is narrowing, and that's driving effort of breathing, and that's what's taking the person out of their sleep. Do sleep doctors look at that, the respiratory effort involved, or can they miss it? You know, have you seen patients, for example, doing a sleep study, and the sleep doctor might say, well, there's nothing wrong with you, but you know that that patient has got issues and you feel that there may be a connection with their sleep? Because it's hard enough to pick up. The AHI is less than 5 events per hour. The blood oxygen saturation typically doesn't go below 92%, but the respiratory effort is higher. And that's the thing to be looking out for. Does that get sometimes overlooked, do you think?
Massively, definitely. And I've had patients that I've referred who do not have normal breathing when they're asleep, but then they have their sleep study, which is just generally on the NHS for one night, and then they're told it's fine. And with one patient in particular, I wrote back to the sleep clinic and I said, there's no way that this person has normal breathing. You know, the description from her husband and her friends when they go away on holiday, she doesn't drink lots of alcohol, so it isn't that. Her breathing is not normal at night. Have you excluded upper airways resistance syndrome? And their sleep study that they'd done on that lady wasn't powered to check for that. So they just gave her a trial of CPAP. But so I think and I think I've heard Vic Veer, who's an ENT surgeon, who's passionate about this, talk about it. And I don't think it's clear how we check for it. So I think it's really easy to miss. And how do you look at it? You know, do you look at it about airflow through the nose? But if they're a mouth breather, that's not going to be a good way of picking it up. So I think this is a real problem. And I've heard one of the sleep physiologists in Australia, is it Danny Eckhart? Yeah. He said he thinks we need to do sleep studies over a longer period of time on multiple nights, because we'll either underdiagnose or overdiagnose. And then he had a particular sleep study product that he thought was the best, but I think that was more to do with obstructive sleep apnea rather than upper airways resistance syndrome. But no, I think it's something that we need more research on that to establish what's the best way of picking that up, because I think certainly from a health point of view, I think this is really important because it drives that sympathetic response, so that fight-flight response when they're asleep, and that very much impacts chronic disease. So you're more likely to have your high blood pressure because you're not having, you know, your blood pressure should drop when you're asleep at night because you're more parasympathetically relaxation response driven. So it shifts the whole autonomic nervous system into overdrive. And that has a massive effect on, you know, conditions such as postural orthostatic tachycardia syndrome, POTS. And again, massively overlooked in that community, the importance of how they breathe when they're asleep. So I think this is really important. I don't know whether it's a continuum or whether it's a separate condition. I'm not sure, but it exists definitely. And I do think, particularly with like persistent pain and probably with like, say, this musculoskeletal syndrome and the menopause, you know, this may be a big part of what's happening, because again, you're driving that inflammatory response, which is going to make pain and any musculoskeletal conditions more painful and more difficult to manage if it's not diagnosed and treated.
There's other aspects that can be related as well. People often talk about diet, nutrition, physical exercise, but breathing, okay, it affects sleep, but sleep can affect your food choices. Will you talk a little bit about that? Because I must think that there's quite a lot of people struggling to lose weight, and maybe they don't consider their sleep.
Yeah. So essentially, obviously, when we're asleep, the fight-flight response should turn down. So the cortisol should turn down. Cortisol is the body's steroid. And then when we're asleep, the relaxation parasympathetic response should turn up. And then we've got hunger hormones and hormones that make us feel full. And there should be a sort of switch in those hormones. And the trouble is if we keep having this fight-flight response being activated when we're asleep to maintain breathing, it will keep the cortisol, so the body's steroid, higher, but it will also mean we don't get that switch of hunger hormones and our feeling full hormones. So it actually makes it more difficult for someone to lose weight, to make healthy choices with regard to their food. And then the more you put on weight, the more the sleep disorder breathing will get worse. So it's this vicious circle, and unless you're thinking, what's the root cause here? Can we treat the root cause and then it make it easier for someone? We need to be thinking like that, definitely.
So that the hormone ghrelin that stimulates appetite, but people may not be unconscious, they may not be consciously aware of it. So, would it be a case that they end up eating, so it's stimulating their appetite, are they eating bigger meals, or could they be just switching to snacking throughout the day and not even realizing that their calorie intake is much higher because you've got this hormone driving it, which is a result of poor sleep?
I mean, the data's quite clear, isn't it? If we don't sleep well for whatever reason, it doesn't matter what, if we don't either give ourselves enough sleep or the sleep quality is poor, we are more likely to crave processed foods, more carbohydrate rich foods, and foods that are more calorie dense, essentially. So it's going to fuel weight gain. And then that makes the sleep disorder breathing worse. So it is just, and those types of food drive more inflammation, which drives more chronic disease. So it's just, we have to start looking at it from a root cause preventative approach.
And that kind of makes sense, because if we're feeling tired and we have to be productive, well, it would be a natural response to resort to sugary foods or something that's going to give us a quick fix or a quick high. So it's a very natural thing, but people don't put the connection there. I like also, in terms of, you spoke about, we put on weight, that feeds back into sleep, and that's a vicious cycle. What could females do? So with your patients that you're working with, what advice would you give them in terms of simple steps that they could take away, in terms of, one, observing their breathing? We spoke about that, but also, yeah, just taking that, what could they do?
So I think I always say, because it can be a completely new topic. So I sort of say, like, aware, assess, and action. So first of all, just be aware. So hopefully if someone's listened to our conversation, they're aware about it. And then just notice how you breathe over the next week or two. And that's your assess bit, isn't it? We can use other methods of assessing it, but just notice how you breathe. And then, not everybody's in the headspace that they want to take some action. And I think, there's a lot going on, and I think I see health and well-being generally as a jigsaw puzzle anyway, but it particularly fits with perimenopause, because there's so many aspects you could look at, but it can be overwhelming for people to think what pieces to work on. So I've got a blog on it on my website, and I literally give it to patients and I just say to them, look, just have a look at it, keep it, just pick one piece that you're willing to work on, that you think you've got the most to gain. So they might notice a piece that they know they'd gain from, but they can't entertain working on it at the moment. That's fine. Park it and come back to it when you're ready, and choose the next piece you've got to work on. And I say work on it, you know, don't aim for perfection. Just work on it with a bit of gratitude, curiosity, and a bit of conscientiousness, and just put it into your life so it's just part of you. And then when you're ready, pick another piece. And how we breathe is one of those pieces. And you can only address it when you're ready to do that. But if you are, then I'd say, you know, the nose is the first easy thing, isn't it? Just, you know, can you just keep bringing yourself gently back to breathing in and out of your nose when you're resting? Can you see if some of your, you know, can you go for a walk and maintain nasal breathing? Can you do that? I think tongue position is really important. And I definitely, you know, I think the tongue is a really, really beautiful organ. And I see it now as, you know, it's an organ, it communicates with the rest of the body. And it's a real marker of our emotions. I've read a really interesting paper on it. You know, tongue position, in certain positions, it can be more to do with you feeling stressed. But when we're more relaxed, the tongue should be, the correct tongue position is up on the roof of the mouth, you know, sort of as flat on the roof of the mouth as you can get it, lips sealed, not clenching, and you don't want the tip of the tongue behind the front teeth because they'll go wonky because it's a strong muscle. So just put the tip of the tongue on the ridge of tissue above the front teeth. And I think just bringing yourself back to correct tongue position and nasal breathing, you're strengthening the tongue, you're putting it in the correct position. So that's going to help. Then hopefully when you're asleep, your body will eventually, if you practice it often enough, your body will remember, and put the tongue in the correct position and your lips sealed. And then you're naturally breathing slower and gentler. And I've read a little bit of data, not lots of data, but if the tongue, particularly the back of the tongue's up against the palate, it does help induce that parasympathetic relaxation response. And we activate more of our memory and learning centers when we're nasal breathing as well. So this, you know, that's so important at any time of life, but particularly around menopause. And I suppose the other thing that menopausal women should know is, you know, we all feel crispy, you know, we all dry out because we haven't got the estrogen, but we lose 42% more water if we switch to mouth breathing compared to nose breathing. In one small study it was. Every menopausal woman should know that. Do you know what I mean? It's like, you know, if you don't want to feel dry and crispy, the very basic you can do is cut down 42% water loss by keeping your mouth closed. Yeah. But there's lots more you can do about it. And I think, you know, having that concept that when I feel air hunger, so that feeling that I feel a bit suffocated and I want to open my mouth, it's not necessarily a bad thing. You've hit your tolerance to your waste product, carbon dioxide. I appreciate that feeling can feel very horrible for a lot of people, but just have that knowledge that actually, generally the oxygen level hasn't dropped at that point. It's just you've hit your tolerance to it. And if you can sit with it comfortably over time, or maybe you're doing a walk and you just keep your mouth closed, you just walk slow enough that you can maintain it, it doesn't feel too uncomfortable. Over time, your body adjusts and it can change and your breathing pattern becomes slower and gentler and you're more likely to use your diaphragm.
I think that's a great point, actually. Air hunger, it's very much a primal fear. And some people can have a very strong fear reaction to it. So as soon as they feel the sensation of air hunger coming in, it can trigger them into a panic. And maybe they don't even realize it, but they are going to be breathing faster and harder. But of course, you're blowing off too much carbon dioxide. That's causing reduced blood flow and reduced oxygen delivery to the brain, which can in turn then feed into brain cell excitability. And it's a vicious cycle. So you said if people are going for, so you run, and even running can be sustained with nasal breathing, and people don't give it. I think running or walking, like I try and get in 5K every morning now.
Oh,
For
wow.
for years, it wasn't good, to be honest with you. I put exercise in the back burner and I focused, work just kind of took over, and that's the way it is, you know. And then I said, okay, I was kind of resenting a little bit, putting all of my attention out and not kind of giving myself some attention. So I said, okay, I have to look after myself first. And sometimes, and I think females will be in that boat because they have family life. they've got work life. So sometimes we just have to say, okay, put ourselves first. Now, people don't have time, Louise, to do one more thing. But how about you go for your run, or somebody goes for their walk? They have their mouth closed. They're breathing in and out through the nose. And when you talked about the air hunger, if the air hunger gets a little bit too much for you, just to slow down, but don't revert to mouth breathing. And kind of surrender to that sensation of air hunger, because it's only a buildup of carbon dioxide, and realize that that slight buildup of carbon dioxide in the lungs and blood is actually improving your blood circulation and oxygen delivery. So it's kind of, breathing is one of those things that's very accessible, isn't it? You know, in terms of just making small tweaks for people to bring it into their way of life.
Definitely. And I think, coming back to your point about making sure you look after yourself, I think I definitely think that in around the perimenopause and menopause, it's so critical. We're often juggling lots of balls. And when I give my jigsaw puzzle to people, I'm actually like, go home and talk to the people at home and say, my body is different. My body is going through a transition, and it's different now than it will be. And I'm more likely to get this, that, and the other. But the way to offset that is I need to spend a little bit of time, not loads, just a little bit of time of looking after myself. And I'm just going to work on just little pieces, and I want you to support me. And I actually say to patients, you might have to say no. You might have to delegate. You might have to get somebody in to do something so that you don't have to do that piece of work. And that's not being selfish. See that as, if I do that, that means that I am more likely to have the energy, I'm more likely to thrive, so I can help you. And that's really helped switch it in my brain. And I like you, I prioritize my self-care, my running, my strength training, my daily meditation and breathwork practice. And that's what I do. I rarely not do it. But I see that as keeping myself well so I can help others. So that's the way I see it. And yes, I could drive myself into the ground with doing more and more work, but then I'll be off sick or burnt out for a year. And that's not helpful to my family or to my patients or clients. So I think that's really important. And I think exactly as you say, you can bring breathing. Obviously, you can do it formally. I do 20 minutes every morning, formal breath practice to help me. But I bring it into my everyday. All my running's nasal breathing, my strength training is all with nasal breathing. When I'm washing up, if I'm doing a really boring task that doesn't need a lot of attention, I can just slow down and just soften my breathing, and it brings a real calmness to it. So I think people can see this as just they're tagging it onto their everyday activities. Obviously, if we have different spectrums, and the people that, I've worked with people who, well, there's two aspects to air hunger. There's people who are intolerant to carbon dioxide, but their bodies overreact to it. So there's two elements, I think, isn't there? And obviously, the more intolerant and the more your body overreacts to it, the more gentle you've got to be, and the longer it's going to take to improve it. But those people have more to gain from it, and they might need to do some more, bespoke, gentle work. But other people, just what you've said, they can work on that and just bring it into their everyday, and it'll be easier for them. But I think it's just so important.
Yeah, it's a really good point. Because with PMS, there seems to be the females who are more prone to it have a very strong chemosensitivity to carbon dioxide, so their bodies react stronger to the buildup of air hunger, and that can generate a fear response. And you never want to do a breathing practice that's going to be putting you into that fear response. So it's all about just going short period of time,
Yeah.
gentle air hunger. So you can change the duration, you can change the dose. I'm just conscious of time. We're coming towards an end. Your breathwork practice, can you describe it? And because I'm curious, I don't know if you'd be doing hyperventilation. I think that you'd be doing more of the lighter stuff.
No, gosh, no. As an ex-snorer and someone who was very significantly over-breathing, there is no way I've done hyperventilation once. I've filmed myself. I put it on my YouTube channel because I heard somebody say it increases oxygen level, and I didn't agree with what they said on the podcast. So I thought, I'll just record myself. So, but yeah, I'll just very briefly, that this person was promoting hyperventilation followed by breath hold in 3 rounds of it. And I wrote down the instructions, I followed it exactly as described, and I filmed myself with a saturation probe, oxygen saturation probe in my finger. And the first round of breath holds, I dropped down to about low 80s. The second lot, I dropped down to around low 70s. And on the third one, I got to 64%. And I know the oxygen saturation probe at that point is inaccurate. At some point, I'll have a seizure, or I will have I'll basically pass out because I've got low oxygen, and I was on my own in the house. So I stopped it, and it actually dropped to 62, but I had no desire to breathe. You know, I stopped myself, and I'm not gasping. It's dangerous, really. So I think hyperventilation, probably a conversation for another day, but this profound I know you know this, profound biochemical and physiological changes that happen. And I'm not convinced that everybody who practices it or teaches it always knows that. From my experience, when I've asked people about the physiology of it, they've not known what when I've described it to them. So, but yeah, you won't catch me doing hyperventilation apart from that one time. So, no, I have a really I have 20 minutes, and it's a breathe light nasal breathing pattern. It's quite niche what I do, and it's an advanced practice. And I share it with people at the end of my programs, because I need to know that they can functionally breathe first. And the trouble is with stuff in social media, you say what you do, and everyone just jumps to that and doesn't put the work in with the functional breathing. So yeah, it's a 20-minute light practice, but I'd rather not describe it because it's a bit more advanced, and so it won't be for everybody who's listening to this.
Sure, sure. So for people to reach out to you, you have a blog, you've got social media?
Yeah, so if my website's Dr. Louise Oliver, therapeuticlifecoaching.com. I'm on Instagram as Dr. Louise TLC, Facebook as Louise Oliver, and LinkedIn, I think, as Louise Oliver. I think I can't remember that one. But yeah, and I've got I put regular blog posts out. So on the self-help page, there's a blog post, and I'm really quite careful of how I present the information, I reference it, etc. So I hope it's a useful tool for people. So but yeah, so I hope thank you very much, Patrick, for this opportunity to talk to you, and thank you for everything you do with breathing and for helping me as well.
Pleasure. Thanks very much, Louise.